This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2017, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Assessment Guided Asthma Education, Match the Message to the Need. Upon completion of this AARC webcast, participants will be able to describe the need for and value of standardized EPR3 compliant assessments across settings of care, compare the use of evidence-based educational interventions to the 6 pharmacotherapy steps advocated by EPR3 guidelines. Identify opportunities to use administrative claims data to partner with insurers and clinicians to deliver reimbursable asthma education to individuals with elevated risk or impairment. I am pleased to welcome Dr. Ben Francisco. Dr. Francisco is a board-certified pediatric primary care nurse practitioner, certified asthma educator, and Associate Teaching Professor of Clinical Child Health and Pulmonary Medicine at the University of Missouri in Columbia. He is also the Program Director of the Asthma Ready Program and the Principal Author of Impact Asthma Kids. Dr. Francisco has no financial interest in any commercial entity discussed in this presentation and will not discuss experimental or off-label use of medications or devices. I disclose I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Francisco, welcome to the program.
Thank you, Shauna. I appreciate the introduction and really happy to be here today. I'm going to kind of move quickly through the slides so we have a chance to talk together and answer questions. So globally, the goals for asthma education, I think, are really to make sure that we do standardized assessments so we can identify the need for and then later the impact of very specific interventions. So asthma education in this respect is not a one-size-fits-all. We also need to use effective interventions, not sort of things that we cook up, but things that have been tested and shown to be effective, shown to improve self-care, and also specific educational interventions that can be delivered by a trained workforce across settings, so something that can be deployed. And that requires, of course, that we have accredited training programs for specific curricula that prepare and mentor workers to administer the educational approach. An important theme that has emerged for me in the last 20 years as an asthma educator is that sometimes healthcare just isn't very efficient and we aren't using the data we have in appropriate ways. So the background question really here today for this presentation is if we were able to join clinical and community assessments with the administrative claims data that insurance companies hold, would those data give us a better approach to both support medical decision making, but to also deploy the right kind of educational intervention for patients who really need help with their self-care or caregivers who are caring for younger children? And would that in the end lower cost and improve patient outcomes? So this sort of a systems approach includes everyone. There would be a role for the pharmacist, for the respiratory therapist at the hospital or in a clinical setting or in the community setting. Certainly a role for the health plan that holds administrative claims data. Children with asthma are at school, so there'd certainly be a role for school services. Specialists have a role, and an emerging role is that of the health home or medical home, where care managers are looking at populations of at-risk patients, such as patients with diabetes or asthma. So as we mentioned, Shauna mentioned, we do want to think a little bit about what are those EPR3 compliant assessments that would give us insight into the needs of patients, and how does the use of educational interventions parallel the 6 pharmacotherapy steps that are advocated by EPR3. And finally, how would we use administrative claims that show how patients are actually picking up their medications or using the emergency room? How could we use that to partner with both the insurance company and clinicians so that we would be able to deliver appropriate asthma education that could be reimbursed and that would, in the end, lower the risk and impairment of our patients? So we're really thinking here about surrounding a person with asthma with both care in the medical settings, but also care in the community. The door for this to happen was really opened in 2014 through the work of a lot of folks, including the Childhood Asthma Leadership Coalition, whose influence and that of others led Centers for Medicaid and Medicare Services to change the rules to basically say that states could choose to reimburse workforce who were providing education outside of the clinical settings of care where we've traditionally delivered education, so in the community, in the home, in other locations. And a lot of work went into really convincing Centers for Medicaid and Medicare Services that this is cost efficient. So many studies have now been published that show a return on investment anywhere from $2 up to a high of $14 for every dollar invested in asthma education, and that includes home environmental assessments where the goal is trigger reduction. So this was actually codified by CMS. And in our state, it actually took about 3 years for the state to submit and receive approval. This is the state of Missouri for a state plan amendment. So just in the last couple of months, Medicaid has announced that they will reimburse folks for delivering asthma education or home assessments. We're still early in that process of finding out how we'll become credentialed and how that reimbursement will work, but there has been a policy change. And you might ask, why was CMS and why are state Medicaid programs considering this type of a move? And really the answer is there's things that we can do in the community that we just simply can't accomplish in the clinical setting, and community asthma partners bring a lot of value to the table for clinicians as partners for helping patients get their asthma under control. I'm not going to itemize each of these, but you can see them on the slides. What I really want to highlight is that respiratory therapists have a major role in many of these opportunities, and certainly in Missouri, respiratory therapists are in leadership roles in a number of these activities. So let me change gears a little bit, and let's think again about the EPR3 guidelines and how would this sort of infrastructure that we have around clinical asthma care relate to asthma education. First of all, the first component of care in the expert guidelines is assessment and monitoring, and the reality is that in Missouri and in most states, Medicaid patients are seen on average about once a year in a clinical setting for the sake of an asthma checkup. And so obviously this is not enough, and so there is a challenge to have meaningful data at an affordable cost that would help us to monitor and respond to changes in asthma status, the control level, at closer intervals. And of course, the other objective in having more checkups happening in more places would simply be to support clinical decision making so that we don't wait until a person is back in the emergency room or hospital to recognize that they don't have adequate self-care knowledge or skills to stay well. I love the fact that in our expert guidelines, the first two items that are tightly coupled are, in fact, the assessment and monitoring of asthma and education for a partnership in care. And actually, medications is the last of the 4 components. And I think the significance of this is simply if you do the first 3 well, we depend less on medications, and the cost of care is considerably lower. So around this idea of there being a relationship between a good assessment and appropriate education, I want to just remind us that there really are 3 global assessments that we have to make again and again in the care of people with asthma. The first is there impairment? And impairment means some limitation. That could be lung function, that could be inability to sleep through the night when asthma is at its worst. Also, the assessment of risk, and risk is the likelihood that a patient will experience asthma exacerbations in the future, or that the medications that are being used to treat asthma actually pose risk for the individual. And then the one that I think is a little underemphasized is responsiveness. And respiratory therapists are probably better than most at thinking about responsiveness, because there's such a wide range here in patients as to whether treatments really are effective. So this is the ease with which asthma control is achieved by therapy. And certainly in the midst of an exacerbation, it's the assessment of airflow obstruction reversibility, and the degree to which symptoms can be reversed with treatments. So responsiveness is super important, especially when you think about folks who their asthma control is not achieved easily, and there may be environmental or comorbid factors that are keeping them sick. And certainly control. We're probably more familiar with the notion that our goal is for everyone to have well-controlled asthma, but the majority of people with asthma actually have not well or very poorly controlled. And there's all sorts of associated costs, and I think this is a basic assessment that an asthma educator would want to make. Is this person well-controlled, or are they experiencing impairment risk related to their lack of control? Certainly for children, school absences, parents' absences from work pose a significant economic burden, which well-controlled asthma can reverse or eliminate. So when we think about the clinical care of asthma, clinicians are taught to assess both impairment and risk and to sort of rate those and correlate those with level of control. Clinicians are also encouraged to adjust therapy, and the adjustment of therapy has to do with going either up the scale towards more potent medications, or going down the scale towards using less medication. That general concept's pretty well understood, but I think the details are often not as well understood. And if you sort of read in the margins of the expert guidelines, it's clear that if you're adjusting medication therapy, it's very important to first check adherence. And that, I believe, involves more than simply asking a patient which medications they take and how often they take them. We're going to talk a little bit about verifying the dispensing of medication using administrative claims. And then secondly, checking inhaler technique. And I think we have done a pretty good job of thinking about the mechanics of inhaler devices, but not as good a job of thinking about how people generate an air stream, an inspiratory flow that's compatible with the particular aerosol, whether it's dry powder inhaler or meter dose inhaler. We can do better. We'll talk about that. And then finally, checking environmental control as well as contributing factors such as comorbid conditions, including GERD. So really, the guidelines are telling clinicians, don't just go up the scale towards more potent medications. First, make sure that patients are actually receiving enough of that at their pharmacy of the current medication to expect asthma to be controlled, and secondly, that the medication they pick up actually is going into the lungs to a reasonable degree, and finally, that environmental factors, particularly in environmental tobacco smoke exposure, is being addressed so that the overall need for medication is not greater because of an ongoing environmental trigger. And then I also think there's a tendency to forget to step down. And so asthma educators, respiratory therapists certainly have a role in recognizing patients who have been on high therapy steps for long periods of time with normal lung function or near normal lung function and no exacerbations. And so the guidelines certainly encourage us to step down. So this really means that we clinicians have to base therapy on the assessment of adherence, inhalation technique, and triggers, as well as comorbid conditions. And that's part of our role, I think, as asthma educators to draw attention to that. And clearly, we all know that inhaled corticosteroids are the gold standard for the treatment of asthma, and that this is for all age groups. And unfortunately, it seems that many patients with asthma really never consume enough inhaled corticosteroids to expect and realize control. And so that's part of our job, is to assess, is it expected that the patient's use is at a level that would result in good control? Now, I get discouraged, and I think most people who look at administrative claims or who call the pharmacy to find out when the last ICS was picked up by a patient, we get discouraged when it's less than perfect. So this slide reminds me and encourages me that whereas we want to see good adherence, 80% or more of the expected medication being not only picked up from the pharmacy but consumed by the patient, the reality is that even much smaller rates of adherence are associated with significant decreases in the risk of dying of asthma. So when I'm discouraged because my patient only picked up 4 canisters of an ICS in the previous 12 months, I remember this graph and realize that at 4, you have cut the risk of dying in half. So certainly there's some good that's done. Where I think we fail is really helping patients clearly understand that ICS, inhaled corticosteroids, are the medications that crush asthma. So if you really want to put your asthma to sleep, take down the bear, whatever language you want to use, it's best accomplished by regular use of inhaled corticosteroids. And I don't think we use enough approaches to help patients understand that this is something that they can have power over that will certainly change the long-term pattern of asthma. So we know globally that there's under-prescribing of ICS. There's also under-dispensing. So the fact that I write a prescription for an ICS twice daily certainly doesn't correlate into patients picking them up and using them at that rate. And I think most of what we're talking about today in terms of effective asthma education is the missing ingredient that would, in fact, bring the prescribed level of therapy and the consumed level of therapy closer together. I don't think it'll ever be perfect. But there's some very specific reasons why patients don't use inhaled corticosteroids. And so we have a critical role as educators in helping them understand the safety and the effectiveness of inhaled corticosteroids, and certainly to be able to distinguish that type of steroid from systemic steroids that are risky and have significant side effects, as well as anabolic steroids that are illegal and have very serious side effects. So, again, images are pretty powerful, and I remember years ago this slide in a course by the Association of Asthma Educators that just captured my attention. And on the right, we see a healthy epithelium with cilia and well-organized basement membrane and a few eosinophils and macrocytes sitting around. But on the left, you see the asthmatic airway. And we actually provide this image in some of our patient education materials because this is the asthma that people cannot see. And this is the process that evolves over the course of weeks or months, and it goes away over the course of weeks or months. So it's the basis for understanding that inhaled corticosteroids, whereas you may see some improvement in the first few weeks, you're really looking at a 2 to 3 month window to heal the airways, to restore the normal structure and function of our airways. So making sure that patients understand this is the gold standard is really important. And then we're big on using pictures. This is an older version of the respiratory inhaler chart we currently use in clinic. There's 10 new inhalers not represented on this chart, but helping patients think through where is my ICS and which of these inhalers is simply a quick reliever that I feel pretty good about taking, but in fact doesn't really change the course of my asthma over time. And then I'm a huge advocate and believer in the fact that one of the critical assessments that we make as educators, and you certainly as respiratory therapists, has to do with airflow. And a fair amount of emphasis has been placed on spirometry, the expiratory characteristics of airflow, but I'm going to suggest that we need to pay an equal amount of attention to inspiration if we want patients to generate an airstream that's optimal for catching aerosol particles and carrying them deep into the lungs. So I have a bias that I believe that we made spirometry too hard and too complex for most of the world. And I love the term spirometry light, which means that I could check my FEV1 at home, or a student's FEV1 at school, or an employee's FEV1 at work. And whereas that's not complete spirometry, if it's taken in context, having an FEV1 is a very powerful indicator of lung health when it's appropriately interpreted. So we do use these devices. There's a number of manufacturers and newer ones coming on the market that link to your cell phone that would allow patients to pay attention to their lung number. So when you look across disease states, people will track their blood pressure and their A1C and their triglyceride and lots of things. And I think that we have fallen short on giving patients and people who support patients in any setting of care useful measures of lung function beyond full spirometry. So when we look at the guidelines, it really turns out, in fact, that the two most important measures are simply FEV1 to FVC ratio, which is a bit more sensitive for airflow obstruction, and FEV1. And peak flow has a decreasing role. That's not to say it's not useful or never important. And I want to add here that this was a tough presentation for me because I think the concepts are important, but we would really want to apply these concepts with cases. So maybe Shauna will invite me back sometime and we'll do the same concepts, but all through case presentations, short case presentations. So recently, with the help of a respiratory therapist on staff here, Mark Schreiner, a couple of the faculty did a study of about 2,000 spirometry sessions among children, and we did it in part because through the years there's been a bit of a debate about the value of the FEF 25, 50, 75, and the 25-75. And at our institution, we've long felt that the FEF 75 is a useful measure of airflow. So I show you this slide for a couple of reasons. One, that the bottom red line represents peak flow, and peak flow tends to stay normal when other measures of airflow are indicating obstruction. So we would say it's relatively insensitive and late as an indicator of airflow obstruction, much like urine sugar, which was replaced by blood sugar, which has been augmented by A1Cs. So we would kind of argue that FEV1 is more sensitive than peak flow, and it's very helpful to have other flows, 25, 50, and particularly the 75, because we see evidence of airflow obstruction early on. So the widespread availability of digital FEV1 meters, I think, signals an improvement in our ability to assess and monitor and respond to worsening asthma earlier. I do want to point out that the limitation of FEV1 in this graph is in large part that it's percent predicted. So had we graphed percent personal best, the sensitivity is better than when you compare an individual to an averaged population or a reference population. So the other reason I'm fond of FEV1 as an assessment is that it tells you a little bit about the patient's capacity to inspire air as well. In other words, the volume of air that you could expect the patient to inhale when they are taking a meter dose inhaler or a dry powder inhaler, it relates to their FEV1. You really can't expect the patient to inhale an FVC every time they take a medication. But there's some simple steps that can help people get close to an FEV1 in volume when they're delivering aerosol medication to the lungs. So we're very much concerned that education should involve the assessment of inhalation technique. And yes, the mechanics of the device are important, but perhaps more important is the assessment of whether the airstream that an individual is generating is optimal, both in terms of volume and the flow rate. In other words, air inhaled too quickly favors the linear pathway, linear travel of aerosol particles, and that leads to impaction. Particles slam against curved airways and are swallowed rather than inhaled deep into the lungs. So in Missouri, every insurance company in the state reimburses for 94664, and we think inhalation, the assessment of inhalation technique is super important, and that we should use objective measures. We should document both the length of time a person takes to inhale their inhale air when they're taking a medication or simulating their inhaler use, as well as the flow rate. And that our role is to coach people to EPR3 benchmarks, which relate primarily to the flow rate, and certainly to use assistive devices when indicated, like valve holding chambers with or without mask and trainers. And certainly doing this once is not as good as having the same coaching approach used many times over time. And these data were published in CHEST in 2007, certainly old data, but it documented that 92% of people with asthma, almost 500 individuals who had MDI medications and used them regularly, 92% of them inhaled 3 times the recommended speed. So it just underscored the fact that most folks need to slow down, and that we can make some observations before and after coaching to see if we're moving towards the EPR3 standard for inspiratory flow rate and inspiratory flow time. So these are the benchmarks, and you can find them on the pages indicated. But meter dose inhalers, I think of them as the aerosol particles are like mist, so they move easily. Doesn't take as much airflow, about 30 liters of flow. However, dry powder inhalers require greater flow, It's more like sand, heavier mass, not as aerodynamic, so the flow rate has to be faster. So a number of years ago, we got the first device in the U.S. That could help us assess inspiratory flow rate in time. Not going to go into detail now about the in-check dial. Many of you use it, but certainly we do have a device that can assess and aid us in coaching patients. We've also developed here at the University of Missouri some patient teaching materials, and we use the terminology, the target time. And the target time is simply how long it should take you to refill your lungs if you're breathing in at the right flow rate. So it assumes the FEV1 is the volume that you're inhaling, and it is sort of predicated on the idea that you gently and completely exhale, because if you don't completely exhale, you will certainly not have room for an FEV1 volume. And so this becomes a pretty simple calculation. Your FEV1 times 2 is the number of seconds required to fill your lungs for a meter dose inhaler, and for a dry powder inhaler, that's a 1-to-1 relationship. We have a lot at stake here, so I think many people are on the right medication. It simply isn't ending up in the lungs. And so with poor technique, no more than 5% of the medication is actually deposited in the lungs, and a much greater proportion becomes systemic, most of that being swallowed, and fortunately with inhaled corticosteroids, much of it's cleared on first pass through the liver, but some of it certainly enters systemic circulation. In the case of albuterol, you have more side effects and, of course, less effect. So a critical aspect of assessment and education. Another component that is really emerging over the last 5 years as much greater emphasis by insurance companies, by insurance plans, or by third-party payers is the assessment of environmental triggers. And in Missouri, we have for the first time a reimbursement code to pay for a home assessment, home environmental assessment. And that standard requires the measurement of several things: carbon dioxide, carbon monoxide, relative humidity, temperature, and particulate count. But more importantly, requires a room-to-room visual assessment and review with the family to identify things that can be changed. So environmental assessments, as well as assessments prior to the delivery of self-care education or self-management education, I think the bar is being raised higher, that there are specific things we should be asking. Here in Missouri, we actually started with Scantron forms for these assessments that required the assessment of inhalation technique before and after coaching, FEV1, impairment scores, and so forth. And there is no shortage of validated instruments for use in doing this, and we like CARET, Childhood Asthma Risk Assessment Tool, as one of those validated instruments. It was developed a number of years ago in the National Cooperative Intercity Asthma Study, and wonderful standardized ways of finding out if there are environmental risk or if there are conditions in the home that are social determinants that may be determining whether someone has well-controlled asthma. This shows 9 different domains that may impact asthma control. We often just think about the drugs and the sort of the way in which people think about medical care and pharmaceuticals, but there are many other things that impact asthma control: who assumes responsibility for medications, the well-being of adults in the home, the environmental factors that we've talked about. So I think the assessment that we're envisioning as part of high-quality asthma education goes beyond simply EPR3 standards and really looks at the family and the home as a unit. So where could we go? Where do we hope we are going in the near future? I think it's so important that the data that are out there that can help us assess patients are available to us. So I know in our health system, we're seeing slowly more pharmacies reporting the dispensing of medications automatically, so that we do not have to pick up a phone and call the pharmacy and wait to find out whether any inhaled corticosteroids have been picked up in the last 90 days. So better data flow really allows us to more quickly assess impairment and risk and move towards providing special care and support. And one place that we've seen great success in providing support to patients who have impairment and risk is in the school setting. And again, we're using standardized data sheets so that the assessment is pretty rigorous, and you know whether the student can breathe their medication in effectively, or if that's one of the educational points that's going to be important. So for school assessments, we've included objective measures of airflow using digital flow meters, FEV1, percent predicted, percent personal best, and percent change after quick relief medication. We're using objective measures for assessing inhalation technique, recording both inspiratory flow rate and inspiratory flow time before and after coaching. We're documenting the self-report of a student who identifies the image of an inhaler and explains how they're using that particular inhaler, or if they're using that particular inhaler on a daily basis. We're using standardized assessments for impairment. We use the Children's Health Survey for Asthma Child version that documents children who are having difficulty with activity or sleep due to breathing problems. We also assess the student's self-reported level of tobacco smoke exposure. And one of the things we see improving with education, both for the family and the student, is lowered levels of tobacco smoke exposure, self-reported by Likert scale. So these approaches allow us to be a little more precise in assessing the level of control for a student, but also identifying the particular self-care areas that need support, need coaching, and also documenting that it has an impact over time. All right, so when we think about EPR3 guidelines, we think about the 7 therapy steps. Not everyone needs to be on step 6 happily. Many people are going to come down the therapy step scale over time, and a large percentage of patients who know how to breathe their medicine and who manage environmental and comorbid conditions actually end up on step 2 or 3 with really good control. So is there a parallel for education? Does everyone need the same level of education? And we think probably not. We think that there's a step 1, and that step 1 is literacy. That means the person with asthma understands the basics about asthma, what it is, and what makes it worse and what makes it better, and how medications are a part of that. There are people who need more intense intervention. So at the steps 7 and 8 on this particular scale, you're looking at sending someone into the home to do a room-by-room inspection. You don't do that for everyone, but we feel like claims data and assessment data can sometimes tell you there's something wrong in the everyday environment, indoor air environment that needs attention. So being able to do an assessment that points you in the direction of those folks who need that intense level of therapy is really important. So when you think about those particular levels of educational intervention, I would want you to also think that there has to be a specific program for each. So each of those steps could be accomplished by applying a specific approach that has a name. It's a program. It's been tested. It's been shown to be effective. And I sadly can't tell you that there's dozens of programs that are already tested and meet these needs, but I certainly would say there should be, that over time we should have more standardized approaches. The items named here are some that we've developed teaming up for asthma control, counseling for asthma risk reduction, acting on behalf of my child to control asthma, and so forth. So who needs those special educational programs? And I think one of the most powerful ways to identify folks who need it are to look at administrative claims. So when an insurance company gets a bill from a healthcare provider or a pharmacy or a hospital or a DME company, those claims, those payments are recorded, and they're collectively called administrative claims. So we've come to think of these sort of three critical data sources. If I want to know how you're doing with your asthma, I do need clinical assessments for sure, but I also need to take a look at your claims data, because I'm often shocked to find out that you've been on 6 oral steroids, you've been in the ER 4 times, and every time I see you in clinic, you look pretty good and you have near normal lung function. So were it not for having access to claims data, I would miss that point. And our dream is certainly that pharmacists, school nurses, respiratory therapists, asthma educators, and others who are out in the community would also be able to contribute their assessment data so that the picture we have of the person with asthma is much better than a once-a-year snapshot of how they're doing. So for a number of years in Missouri, we've had administrative claims where for one patient, I could look and I could see all of the pharmacies they'd been to. I could see all of the medicines, how much they got, the date they got them. And this is very useful, but not very time efficient. So in Missouri, we're moving towards the analysis of claims for groups of people and development of alerts so that at the point of care, whether that's asthma education or in this case a pharmacist, there's some analysis going on in the background and an identification of risk factors. So for example, the program that's used by Medicaid here in Missouri will alert the pharmacist at the point of care that this patient is not picking up enough inhaled corticosteroids or has had more than 3 albuterols within a 6-month period or has no record of a charge for spirometry in the last 3 years, and so forth. So clearly, if you have those kinds of data, you have the chance to develop sort of asthma control monitors so that you can highlight in red for a given patient where the risks appear to be, so that at the point of care, whether you're the educator or the clinician, you can address those risks in a more meaningful way. So we're happy to say that we've pushed for a number of years for insurance companies to recognize the value of education and to recognize that they have a role in helping us see patients who are not doing well, who are falling through the cracks. So we are, for the first time now in Missouri, seeing that all managed care organizations are under an asthma clause that requires them to reimburse for asthma education as well as for home environmental assessments. And that's a great first step. We think that what's going to really change things is an active partnership and a dialogue where we learn together, where we increase the workforce in counties and in cities where we simply don't have enough people to go to the school or to go to the home to provide these services. I'm going to stop there, Shauna, and kind of open up for questions and comments.
Thank you very much, Ben. That was fantastic. And we have a lot of questions, so our audience is really engaged out there. One of the questions that came through was about wondering if there was any data suggesting that after a certain period of time, there is a need for re-education on asthma control steps.
Yeah, I think the answer is clearly yes. And in part, you can see that in claims where someone uses inhaled corticosteroids at a pretty high rate, say 4 inhalers in a 6-month period, and then they go 3 months with no inhaled corticosteroid pickup, and then they're back in the emergency room and they're back on oral steroids. So one of the things that we're trying to help clinicians as well as individuals with asthma and families understand is your risk today has to do with what you've done in the last 90 days. So no ICS in the last 90 days, new exposures, whether they're seasonal allergens or whether there's grandma came to visit and smoking in the house. You really have to look back and be circumspect to how did we end up here. And sometimes there's a need for an educator at that point to step in and say, can you see this relationship? It looks like there was no ICS pickup in January, February, March, and then you had an intensive care unit admission in April. And we see this, day in, day out. So definitely, people fall off the wagon. They stop doing the things that keeps their asthma under control, and there's a need for additional education and support.
Thank you very much. The next series of questions, I'm going to try to collapse this into a common theme here, is about that in-check dial. Now, it's been several years. A lot of folks are using the in-check dial on a regular basis. Two parts to this question. Has a device such as the in-check dial really made a difference in helping our patients, helping us understand what our patients can and cannot do versus just educating on technique? And do you think it would be beneficial if we were able to somehow build that into an inhaler, either an MDI or a DPI or whatever device we have, so at the point of administration, the patient gets some sort of external cue?
Yeah, those are both great points. So the data that we have, which is school-based data, shows that as students' inhalation technique improved, so did their FEV1. And in this group, their ICS consumption went up modestly, not a big increase, but inhalation technique improved a lot. Their FEV1 went up, their impairment went down, their psychosocial functioning got better. And this is not the rigor of a randomized controlled clinical trial, but for most of us who've spent years doing this, this is common sense that you have a very potent medication, but it is of no use if it does not end up deeper in the lungs. So better inhalation technique. I can document it by saying before instruction, the inspiratory flow rate was 110 liters for less than 1 second. After coaching, it was 35 liters for 5 seconds. And I think we have enough objective data about respirable particles to know that in the second case, the likelihood of having a dramatic increase in the deposition of the medication deep in the lungs is really there. On the second part of your question, it's very interesting that there's a scrambling going on in the pharma world to buy up companies that are putting chips in inhalers or attaching gizmos to inhalers, because we get two things potentially. We get a date stamp of the time and date when the medicine was actuated or the aerosol was inhaled, and potentially you could have feedback. And I've long wondered why there hasn't been a digital version of the in-check dial, and I've long wondered why, if you're going to pay $400 for an inhaler, it can't be smart. So I think both of those conditions are going to change in the near future.
I very much look forward to those smart inhalers. I think that all of us with our smartphones would be really excited about that. Moving on to a new topic, though, there are a lot of questions that come from our families about the use of inhaled corticosteroid for asthma and how those inhaled corticosteroids can have side effects in our patients. Do we have side effects, a lot of side effects from high-dose inhaled corticosteroids on our kiddos?
Yeah, so again, really good question. And I think here's the best way to answer it. You have huge potential for benefit from using inhaled corticosteroids if you have persistent asthma. And it's our responsibility to show families and people with asthma their deficit, to show them that their lung function is abnormal, and then to show them that it corrects when you actually use inhaled corticosteroids as prescribed for 60 to 90 days. We have an equal responsibility to monitor for side effects. So if that's a child, that means that at every visit we're tracking height for age. And if there's any evidence of stalling, slowdown in the rate of growing taller, then by all means we should step down or stop inhaled corticosteroids, depending on the case. So an open dialogue and active assessment and monitoring would solve, I think, many of the fears and the hesitation that we see with some people using inhaled corticosteroids. And here's the other global thing I think we need to all remember. Asthma stunts growth. This was evident in the literature 20 years ago, well documented. Asthma was a stunting condition. In oral steroids stunt growth. As few as 4 oral steroids are associated with deceleration of linear growth. And more importantly, perhaps today, weight gain, a lot of weight gain. And then finally, inhaled corticosteroids can stunt growth. And they're most likely to stunt growth when you have really good lung function, because most of the absorption of inhaled corticosteroids is actually through pulmonary absorption. So if you have uncontrolled asthma and decreased lung function, you're at less risk of having systemic side effects than someone who has normal lung function and on high-dose inhaled corticosteroids. So certainly inhaled corticosteroids should be stepped down when you have well-controlled asthma, normal lung function, and every 3 months we should step them down, and we should discontinue them when someone is well-controlled on low dose and then monitor again. The relapse rate seems to be pretty high. A large number of people are going to show their asthma again once you entirely remove the inhaled corticosteroids. But it's an active process, and it's one that we talk about so families understand where we're at. They help make decisions. That's the partnership in asthma care.
Thank you very much. Those are all really great points to consider, and I think I had forgotten that asthma had been proven to be a stunting condition. Moving back to your discussion about target times, the question came in, when you're calculating that time and you're using the FEV1 in that equation, are you using the predicted value for FEV1 or the actual FEV1 measured for the patient?
The actual FEV1. So the target time is an estimation. You take the FEV1 today. In the case of an MDI, multiply it times 2. You coach the individual to gently and completely exhale, to aim up so the pathway of the medicine is all downhill to the lungs, and to fill your lungs in your target time. And if you're using an in-check dial, you then look to see, is the flow rate close to 30? And was the inspiratory time approximately the target time? So it's a method to help in the self-regulation of inspiratory flow in time. So when that person goes home, they don't have an in-check dial, but they really don't need one. If they get the old air out, aim up, fill up in your target time. And we try to make it that simple that a 7 or an 8-year-old would come back to clinic and they would know their target time and they would do those 3 things well. Get the old air out, aim up to open the airway, and to fill up in a target time.
Thank you very much. And I think we're running out of time, but I want to take a few minutes to lump together a few questions about medication devices, nebulizers, metered dose inhalers. A lot of patients are sent home with the same medication in both MDI form and nebulizer form. So do you talk about when it is appropriate to switch from one to the other? And then the use of chamber devices.
Okay, so I'll start with the last question with chamber devices. HFA medication still comes out at about 40 miles per hour, and it goes not only forward, but it goes up, down, and laterally as well. So putting it into your mouth and discharging it results in a relatively large amount of medication swallowed. The data we have that's most graphic came from scintillagraphs of flunisolide that was done years ago with CFC. To my knowledge, there's nothing comparable out there for HFA. So we do recommend valve holding chambers for all MDIs, one, to decrease oral deposition and systemic absorption, and two, to provide feedback for those folks using a valve holding chamber with a flow signal so that if you're inhaling at twice the recommended speed, there is some feedback. So your first question, we are concerned based on what we see in clinic that when people are having an asthma exacerbation, they can have large decreases in airflow that are certainly going to impact their ability to inhale the inhaled corticosteroid. So in our minds, it very much makes sense to pre-treat prior to your ICS doses for those days when your symptom level is up, when you're in the yellow or the red zone. And I think you can argue that if you have a nebulizer, the cost of albuterol and ipratropium is quite low by nebulizer, about 16 cents for a dose of each of those medications, so 32 cents. And giving that 20 to 30 minutes prior to your ICS is likely to bronchodilate you and likely to result in an increased dose of ICS in the peripheral airways. We also provide all patients with a step plan so that they would be, in general, doubling their ICS dose for 1 week during those exacerbations. And I know we're all waiting for the update on EPR3 that will address step plans as well as intermittent use of inhaled corticosteroids. But in the absence of a huge amount of evidence, this is a practice that we've had for more than a decade that cut our oral steroid use to about 5% of what we were using prior to the use of ICS step plans with pre-treatment, usually with a nebulizer for our more severe patients prior to ICS dosing.
Thank you so much, Ben. I wish we had more time to talk, but unfortunately we are out of time. So thank you for joining us.
Thank you.
And thanks to everyone who joined us today. Please join us for our next webcast on Tuesday, June 6th, when we welcome Dr. Jerry Christian and the LOT study update. And then again on Tuesday, June 22nd that's Thursday, June 22nd, with a discussion of pediatric ARDS with Dr. Ira Chaffetz. Thank you for joining us and have a great day.
All right, everyone. In just a moment, you will see a Submit Credit button on your screen. If you are an individual who has registered for this program, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the button here. If you're a group participant, please have your group leader submit your information to the Group Attendance tab at the top of your screen to be provided with follow-up instructions on how to submit for credit. This does include today's presentation. Simply exit the webinar. We hope you have a wonderful afternoon.